So oxygen delivery, first I would check if there is a Bodac seal on the regulator. There is. So now I'll attach it to the oxygen bottle and do a quarter turn to tighten the regulator to the bottle. I will now check the oxygen in the bottle. Yep, that's that. Now I'll test the flow rates. As you can tell, they are working. I'll be using an acute mask in the patient, which has a flow rate of 6 to 8 litres per minute and delivers 60% oxygen. I'll now attach the tubing to the bottle, turn on the flow rates, place it upon the patient, ensure it's on tightly. Now I'll remove it from the patient. Turn off the flow rates, remove the tubing, turn off the pillar valve and release any remaining oxygen from the regulator. I'm going to be demonstrating the use of the suction machine now. First, you must place the patient in a lateral recovery position. We now test the machine by turning it to a level of 350. We're closing the pipe, checking that the levels rise to 350 millimeters of mercury. If that doesn't work, check for any ruptures or blockages. We also include the end of the hard pipe like so to test the suction. When inserting the hard catheter, only insert it as far as the eye can see and remove it in a sweeping motion. Suction should only be on the way out, and the time of suction should be less than 10 seconds. 5 complications that can arise from the usage of the suction machine can include induced vomiting, aspiration, boxus, bradycardia and soft tissue trauma, and one should never use it in a moving vehicle.
I'm going to be demonstrating the use of an OPA in airway management. First, you want to tilt the head back, like so, to open up the airway. Then you take the OPA and measure it along the patient's jawline to see if it fits. Then you take the top end and insert it towards the top of the mouth, and then twist it 180 degrees to avoid catching the tongue. Then you wish to assess if the patient has accepted the OPA. Complications can arise such as induced vomiting, if the OPA is too large, damage to oropharynx or worsened airway obstruction if you push the tongue posteriorly. Reasons for using an OPA is if a patient has GCS of less than 8 or scoring less than 2. Another form of airway management is with the use of an MPA. You measure an MPA from the mandible to the top of the nostril. To insert it, you must first lubricate it with a water-based lubricant, and then take it at a 90-degree angle and insert it as so. If you encounter any resistance, you can turn it to 180 degrees, or you can insert it in the other nostril. And you want to insert it until the phalange reaches the top of the nostril. The benefit of an MPA is that you're not inducing gag reflex or vomiting. They can be inserted into a patient with high GCS scores and in patients with trismus. MPAs are contraindicated for basal skull fractures and any complications that may arise are nasal polyps and bleeding.
I'm going to be demonstrating the use of an ECG machine. To check the batteries, press the button here and all the green lights are showing. If they have run out, to remove the batteries, squeeze at the sides and pull out. To check in the paper, we just do this. We have enough. Pop it back in. I'm now going to switch on the ECG to manual mode, and now we're going to perform an operations check. And another operation check. Before I run it, I'm going to attach the test load, otherwise they will show up as systole. I now have to turn the knob to 150 joules for it to progress, for it to register. Now I must press the charge button, and now the shock.
Shock delivered.
and it's asking me if I had shock delivered. I did, so I acknowledge that. While it is performing the rest of the operations check, I will conduct a physical inspection of the rest of the ECG. We have here the SpO2 detector, the 3 leads, and here the ET-CO2 can be connected. You just lift up this and it is hooked into there. On the other side, we of course have the test load. We have the defib pads here. We also have the puck, which is exclusive to the MRX machine. This is the model of this ECG. Right, the operations check has completed. Now I will stop the printing by pressing this button here. And now exit the operations check. And now it is restarting. And I will now switch it back to manual mode and remove the test load. Also, if we wish to check the blood pressure, we can press this button here. I'll also just demonstrate how to change the volume and the waves. So we enter into the volume here, and then go into the QRS volume. And as I go through, you'll detect the different levels of volume. Okay, now it's off. And now we go to the displayed waves. And now you will see the waves will alter its size. Now they're the largest. I'll just resume normal size. A quicker way of cycling through the waves is to press this shortcut button here. To administer a shock, we're just going to turn the dial up to 50 joules. Then we'll take the test load and connect it. At this point, we now press charge, and now shock. And now if we have begun charging and we wish to stop the shock, press charge, and then press disarm. And to switch from manual mode to AED, you just turn the knob like so.
Apply pads to patient's bare chest. Plug in pads.
Today I'm going to be testing Maddie's radial pulse. The minimum systolic pressure is 80 milligrams of mercury. The average range for a healthy adult is 60 to 80 beats per minute. I'll be testing her for irregularity. If there are any irregularities, it could indicate cardiac dysfunction. I'll also be testing to see how strong or weak it is. First I'll ask for consent. Maddie, may I take your pulse? I'll now count for about 15 seconds. So Maddie's pulse was strong and regular and amounted to 16 beats. We times that by 4, that equals 64, and that is our total radial pulse. Now I'm going to be taking Maddie's blood pressure. First we'd have to remove any restrictive clothing from her arm, which we've done. And then we put the BP cuff on her upper arm. First I must gain consent from Maddie. Maddie, may you proceed? Now I must locate the brachial pulse, which is located on the medial side of the elbow. Yep, there we go, I have it. Now I'm going to inflate the cuff until I can no longer feel the pulse. Once I'm done with that, I'll give it one more squeeze. That's time for the one more squeeze. Now I'll place the stethoscope where the pulse was last felt and take the measurements. I will slowly release the stopper valve and so I can locate all the sounds. Okay, so Maddie's systolic measurements were 110 and her diastolic was 70. Normal intensive measurements have the systolic as below 140 and the diastolic is below 90. Maddie's measurements fall within that healthy range. Hypertensive measurements, however, have the systolic as above 140 and the diastolic as above 90. Today I'm going to be performing a respiratory assessment on Maddie. I'll be counting her chest rises, and then I'll be over 10 seconds, and then I'll multiply them by 6 to gain a respiratory rate. Maddie, may I do so?
Mm-hmm. Sure.
Okay. Maddie okay, Maddie breathed 3 times, so that means her respiratory rate is 18. Now, I have now taken Maddie's respiratory rates. She breathed 3 minutes over the space of 10 seconds. Multiply by that by 6, and that's 18, which falls within the normal range of 12 to 20. I've taken Maddie's respiratory rates, and now I need to check the clarity and integrity of her lungs. In order to do this, I must place a stethoscope on her mid-axillary line and place it upon the base of her lungs, both posteriorly and anteriorly. Maddie, I need you to take several deep breaths in through your mouth and back out through your mouth again. May I proceed?
Yeah.
Thank you, Maddie. Maddie's lungs both appear to be functioning equally and clearly. Today I'll be demonstrating the use of the bag valve mask. I will now check to see if there are any visual ruptures. There are none. I'll also occlude the port to see if there's any disturbances. No, there is not. I will now attach the oxygen tank to the bag valve mask. Now attach the mask. I'll now set the oxygen to a level of 15. As you can see, the bag is now inflating, indicating that there are no ruptures. I'm going to turn my attention to the patient. I will place the OPA, check the measurements. As I am a single crew, I will be adopting the CE grip, placing the mask correctly and tilting his head back to allow maximum oxygen passageway to his lungs. I will squeeze the bag twice. You will see his chest rise accordingly with each squeeze. There will be a space of 5 to 8 seconds between each squeeze. 1, 2. Preferably, a second crew member will now also place his fingers upon the larynx to prevent gastric inflation. In a situation involving control bleeding, one must first expose the wound for checking and then take saline solution to clean it. And then we take the dressing, sterilise it with the saline solution and apply it to the wound. As so, and maintain pressure at all times. We then take the bandage and whilst maintaining pressure, begin rolling the bandage around the wound. Another way to do this is to do the crossover, so turn it as so to increase the pressure. Another way of doing it is in the figure of 8 for more pressure, as so. If the bleeding continues to persist, you can place a second dressing upon the bandage. Another way is to raise the arm, or place a second roll of bandage as indirect pressure underneath the armpit. If bleeding continues to be uncontrollable and it has reached catastrophic levels, one may use a tourniquet. Once it has been placed on, one can tighten it by winding this up, like so. We can also administer the use of pain relief, as tourniquets can be extremely uncomfortable. We also check for distal pulse to make sure it has ceased circulation. We also note down the time of when the tourniquet was applied. We write it here. And lastly, we must make sure that bleeding has indeed stopped.
With the application of the cervical collar, first I must gain history of the injury and, if possible, the mechanism of the injury. I will then assess for posterior midline tenderness. Once that's done, I will then apply the nexus rule, which is neurological deficit, intoxication if it has an extreme distracting injury, an altered level of consciousness, or spinal tenderness. Once I've done that, I will then measure for the cervical collar. To measure for the cervical collar, I will place my fingers between the trapezius muscles and the jaw. I will then take these measurements and transfer it to the cervical collar to see how much is required. I will then make sure the patient is in neutral alignment and then slide the collar beneath the neck, placing over the jaw and then strapping in tightly to restrict movement. So in the case of fracture management, first I will ask the patient for his consent to proceed with exposing the wound, which I shall now do. I shall also expose the opposing limb to compare the differences. Now I'm going to ask the patient if he could rate his pain on a score of 0 to 10, 0 being none at all, 10 being the worst imaginable. I'll also be running for the rest of the plus discs acronym to determine if it's indeed a fracture. That would be loss of function, anything unnatural, swelling, deformity, irregularity, crepitus, or shock. If the pain is indeed moderate to severe, I will administer pain relief known as Entonox. I will be assuming the patient doesn't have pneumothorax, bowel obstruction. I shall also ask if he has been diving the last 24 hours, and if he is obeying his commands, and if he has any known allergies. In the case of Entonox, I will have to inform the patients that the side effects include sedation, euphoria, nausea, and metallic taste, and auditory echo. It takes about 5 to 6 breaths to administer and 2 to 5 minutes to wear off.
Alright, to create your splint, we will use a cardboard cutout, place a towel in the middle, and 2 straps to tie it up. I will now ask Maddie to support the limb on either end, so I can slip the splint under. Thank you, Maddie. Lower it. Now we're going to tie it up. Right, so the splint has been tied to the patient's limb. I will now check the neurological and cardiovascular integrity again. The temperature appears to be fine. The capillary refill has continued. The colour is about right. Still feeling sensation or touch, and I'm still detecting a distal pulse. Okay, seems safe. You can set up over there. I'm going to check for a response. Hello, sir. Can you hear me? Can you hear me, sir? Check for breathing. Yeah, no breathing. I'm going to call in for assistance. AUT1.
Receiving.
I'm going to need an R49 for an R50.
Copy.
Okay. Back up this way. I need you to start doing chest compressions. Oh, I set up the EED hits. Once you hit 25, let me know.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient.
Clear the patient.
Deliver shock now. Pre-shock delivered. Pause. Start CPR.
May I resume? After this round, I'll be in 2 minutes and we can swap over. And swap.
Whenever you're ready.
Whenever I'm in my paramedic shirt, in fact.
Oh yeah.
Today I'm going to be performing a respiratory assessment. I'll be using Maddie. Today I'm going to be performing a respiratory. Today I'm going to be performing a respiratory. Oh my god, it's such a fucked up sentence. Fuck. Who came up with these words? Okay. Today I'm going to be performing. Fuck you! I was gonna be fine! God damn it!
It was so fast. It's like, what was it? Heckle and Clyde? No, the doctor and
Oh, Jekyll and Hyde.
Yeah.
This is so going to bloopers. I'll just bleep out all the swear words.
Cut out the actual.
Wait, I'm just gonna stop it. Go whenever you're ready.
Oh shit.
Be the bloopers. Fuck
Yeah, fuck it. I fucking had it with Elliot. If I ever meet the cunt, I'll knock him on his ass. Be sick of him instantly the minute he opens his mouth. Right. Fuck. Can you tell we're overtired? Ready?
Oh, it's rolling.
Oh shit. Okay.
I've recorded all that.
Oh my god, I'm fucked. Okay, I was fine till you laughed. Fuck, okay. What was that? Was that a Chewbacca? Oh.
Oh no.
Okay, guys.
Oh my god, finding the star of this is gonna be a nightmare.
Do you want me to stop?
Yeah, might as well just stop and start new.